The next speaker, I think, is pretty well known nationally. Janet, it's a pleasure to meet you. She's a very established author. She's a genetic counselor, has written a lot. She's a brand ambassador for PFF Foundation. She also runs the National Helpline, I believe. She's the director for Familial Pulmonary Fibrosis Helpline, and I'm looking forward to her talk on genetics and ILD. Thank you, Janet.
Thank you. Can everybody hear me? Okay. Is this the clicker? Okay. Well, yes, some of you may know me in the audience. I've either visited you or you visited me at some point. I've been with the Interstitial Lung Disease Clinic in some form or fashion for 16 years. And this is I've been to every summit now, so I'm really pleased to be here and honored to be speaking again. So I just put everything on my disclosures just in case. I work more these days at a company called Informed DNA, and I've been there. I'm a senior genetic counselor. I'm working in oncology and ocular genetics and hoping to build a program for pulmonary fibrosis as well. I've been at National Jewish Health for 16 years. I'm currently more of an advisor kind of role there, and of course many of you have seen me as a healthcare ambassador, and I'm on the advisory board. I'm a Scorpio. My birthday's coming up, so so I can't even see that one. So a little more, but Dr. Danoff mentioned the Familial Pulmonary Fibrosis Counseling Program. My manager, who some of you might know, Dolly Kurvitsky, she had the foresight in 2007 to create some kind of national telephone line when the telomerase genes were first announced, because there were already laboratories testing for those, and we were concerned that patients wouldn't get the right information surrounding all the limitations that Dr. Krotsky has already mentioned. So that's still going on. It's mainly supported by grants and private donations, and people mostly find it very helpful. And I also participated in the Familial Pulmonary Fibrosis Research Study for 11 years. I ran that study there at National Jewish Health, and I saw patients in clinic as well. So today I'm just going to kind of go over, a lot of people don't know what a genetic counselor is, and even my Lyft driver last night was peppering me with questions. But, and just kind of, Dr. Kropsky's kind of giving you a primer, but I'll just kind of reinforce it with a little different way to look at it as well. And just kind of go over those questions about genetic testing and the issues that come around, and some of the risk and benefits, and provide some resources. So a lot of people say, well, what is a genetic counselor? And we're specially trained, master's degree level healthcare providers in medical genetics, and board certified through a genetic accreditation council. And we have some training in the psychosocial aspects, because a genetic diagnosis can really impact a family or an individual. Because if you just think of all the psychology behind that, of passing something down or having a child with a disease, and then you might have more children. So classically, it's been around, in fact, I just came back from the National Society of Genetic Counselors meeting, where our profession's officially 40 years old. So it really stemmed out of pediatric and prenatal care. And as we've learned more about the genome, it's spread out into all kinds of diseases. Dr. Krotsky mentioned that at the end of the day, IPF is a genetic disease, and I would say that most diseases that aren't acquired through viruses or bacteria are going to end up with some kind of genetic component as we all age and our DNA kind of takes hits from the environment. But some people may have experienced or ran into genetic counseling through pregnancy, prenatal, or even preconception, or in the pediatric realm if their child was diagnosed with a rare disease. But now, genetic counselors not only traditionally work in those clinics, but also in laboratories, helping interpret test results, write clinical reports, research, like what I did for several years, everything from design or run studies, publish. But at the end of the day, what I've been surprised is it's all about educating. I'm educating you guys. I educate physicians about the genetics of pulmonary fibrosis. Interestingly, we're a majorly female workforce, and we just surpassed 5,000 genetic counselors in the country. But I would say there's at least 5,000 genetic conditions, and there's 20,000 genes. So there's not enough of us to go around, right? So in the genetic counseling process, people say, well, I have a gene mutation. What am I going to do about it? And it's not about like a psychological counseling. It's more about a conversation with a family about how a genetic diagnosis impacts the patient, impacts their family members, how it might impact their medical care. So in a genetic counseling session, first of all, we look at family trees, like I think it was Dr. Garcia who had the pedigree today. That's our bread and butter as far as evaluating what's going on in the family. We're looking for patterns. We're looking for diseases that travel together that might give us a clue in what kind of direction to go, what gene to test for. And so also, what are the risks? It's not just a simple blood test. A lot of people will come in and say, hey, I want to be tested for the gene for pulmonary fibrosis and find out if I have it or not, because I have a family history. And we've already seen from Dr. Kropsky, it's not that simple. It's not a single gene disorder. We can also help facilitate the ordering of the test if we don't order it directly with a physician. And we can help interpret those results, and they can be quite complicated as well. And how does that impact? Is that going to change the care of the patient? For instance, in the cancer world, if you have a mutation in a gene called BRCA1 or BRCA2, we know that you can try to prevent cancers of the breast and ovaries and possibly the prostate, or, well, not prevent it, but be monitored for it, change your clinical management if we know you have a gene ahead of time. Unfortunately, right now, we don't have that for pulmonary fibrosis because we're still learning, but I think in the future, in the near future, we might have some screening guidelines, as his last question was, Dr. Kropsky's. And of course, once you find a gene mutation in a family, you want to think about risk for others to carry it. Is it a 50% risk? Is it a 25% risk? And just provide that psychosocial support of a genetic diagnosis. Some people are happy when they find out what the cause of their diagnosis is. Not necessarily IPF, but in other genetic conditions. Oh, now I know. I even had one lady laugh very well about a breast cancer gene. But she just, it just crystallized everything for her and her family. But, some people don't take it as well. They have more to worry about, even if they don't have the diagnosis. So just providing that psychosocial support and resources for the patient as well. So I always think about IPF, like many other complex diseases. Most of them are sporadic, where there's only one case in a family that has it. I could change that lettering up there to say Alzheimer's, cancer, cardiovascular, you name the disease, I'll put it up there with a pie chart like this, almost all of them. But a subset is familial, and out of that subset, we call it hereditary, meaning we can find a gene mutation for some of those families. These are the pedigrees. We color in the index case, or what we call the proband, someone with the diagnosis. This is your typical patient with IPF with no family history. Squares are males, circles are females, and then you have 3 generations. But when you contrast that with these familial pedigrees, they can be quite impressive. Now, these are ones I've kind of made up or altered, but I just wanted to highlight some things. Let me see if I can make this work. Okay. So when Dr. Kropsky was talking about dominant inheritance, a pedigree might look like this, where every generation is affected, and most people with the diagnosis have a parent who was diagnosed. Incomplete penetrance, or what we call reduced penetrance, is when we have, it looks like it skips a generation. A lot of people will say, well, the gene skipped a generation. Genes don't skip generations. They either get passed down or they don't, but the disease can skip. So let's say there's a gene mutation in a telomerase gene in this family, came from grandpa here, went into these individuals. This person didn't get the diagnosis, but still passed it down to his son, and he came up with it. So that's complex in itself. So while we think that in these families, the unaffected family members might be out of the woods, we can't guarantee it. But we do think their offspring might be at a little lower risk, but we don't know until we know more about the genetics. We also see families where only one generation is affected. Most of the time in genetics, you would think more of a recessive disorder, where each child had to inherit a copy from each parent. But we're not so sure. You know, when you start, I always ask how old the parents live to be. You know, maybe they didn't develop it because they, you know, were in a vehicle accident or something. So I just have this up for illustration. So again, you know, genetic counseling is about how genetic information can impact in the role of the disease, what genetic testing do we want to choose? You know, we don't want to look in the wrong haystack. We want to look in the right haystack. Is it going to change a person's diagnosis or clinical care if we do genetic testing? Is it going to rule something out? A lot of times genetic testing will confirm a diagnosis, but it can't always rule it out. You may still have IPF even if you don't test positive for a gene mutation. We know that. A lot of people have questions about confidentiality and insurability. I have some slides on that, and I've already kind of been talking about the psychosocial impact. So I have a similar slide. I got it from Dr. Christine. I've updated it. But I think this slide alone demonstrates why genetic counseling or a genetic counselor or somebody who specializes in this disorder needs that service, because there's so many genes that have been described. They kind of do different things. They appear differently in some families. Some of them are the common variants, some of them are the rare variants, and I'm mainly going to be hanging out in this area today. Some of them are kind of in between, important for both. If you notice, this TERT gene even comes up in the common variant, so it's a pretty important gene in IPF, and it is the most common one in familial. So I think navigating this for a patient is really difficult, and even physicians who aren't experienced with this may have trouble with this. And so that's where genetics can come in, genetic counselors, medical geneticists, or doctors who specialize or have some background in this. Okay. I'm going to highlight DNA a little bit differently than Dr. Kropsky did. So we all get those chromosomes from our parents, and on those chromosomes, they're in every cell of our body. That's why on CSI and everything, they can take a little stamp lick and find you. But these chromosomes are just tightly wound coils of DNA, and our DNA is made up of a nice code of 4 letters and makes it really good for data capture. And genetic mutations and genetic conditions can come from anywhere in this process. Most of you know about Down syndrome. It's a whole copy of a chromosome. So there's 3, it's a dosing effect. Or you could have a whole arm of a chromosome missing, or you can have it moved somewhere else, and it does, but our genes live all along these, so breakpoints are important. And also, you can even have entire pieces of the code missing or duplicated, like Dr. Kropsky mentioned. But sometimes, many of the times, you just have 1 letter off, and that's all it takes. And I like to refer to mutations like typos in a book. Your gene, imagine your genome, that 20,000, is a library filled with books. And so in those libraries, you have 2 copies of every book. So you really have 40,000 books. When we do genetic testing, all those genes that Dr. Kropsky mentioned so far, those are individual books. We're going into those books and we're trying to see if there's a typo And we don't know what we're looking for. We just know that those books have been associated. And just like in our written language, we have harmless typos like 2, 2, and 2, there, and there. We have pretty blatant typos where you can't read past that word. Maybe it's a blank page after that, or maybe the language changes. Or sometimes we have some head scratchers, like maybe you're reading a cookbook and something about a backhoe shows up in the middle of a paragraph, but you just kind of keep moving on. You're like, what was that about? I don't know. And we call those variants of uncertain significance because we all have changes in our DNA, as he mentioned, but sometimes they do nothing, sometimes they do something, and sometimes we don't know what they do. And I'll just kind of cap off these points about genetic variants. I always say less than 1% in the population, but do I need to update that? Okay. But I think of rare variants is that rare disease, what you've always heard about from genetics, right? Huntington's disease, cystic fibrosis, sickle cell, rare cases, breast cancer. These are the hereditary patterns, dominant, recessive, X-linked, and they have that stronger effect, and the variants can be anywhere in the gene. There might be hot spots, but they can be anywhere, and in IPF what we're finding is they can be private to each family member. Versus the common variants, and I think again, I have 23andMe on here, that's what they take advantage of. Ancestry tests, just little bitty typos in that library that they happen to be looking or marked. So that's why you could do a 23andMe test with your sibling and you come out with different percentages because these typos get moved around too. So really, pulmonary fibrosis and all these adult onset conditions are more multifactorial. Everybody starts out with a genetic predisposition of some sort. Sometimes those are protective changes. Some of them are harmful changes. And then our environment, as we live our lives decade after decade, we acquire more hits to our DNA. And our DNA just makes more mistakes as we get older, right? We all do, right? So our DNA does too. But if you start out with a harmful mutation or rare mutation, you kind of start out with a little bit shorter end of the stick there. And that's why you usually see genetic conditions start at a younger age than average. So in a genetic counseling, with all these array of genes, what we want to do is we want to get the right test for the right patient. We know that there's multiple genes already. Luckily, with genetic testing, costs are coming down. We can test for multiple genes at one time now. So we do these things called panel tests. Sometimes we can just kind of blast everybody with panels, but there's definitely some genes. And early in Dr. Kropsky's talk, he mentioned that there were some rare hereditary syndromes that had pulmonary fibrosis. Some of those are genes involved with like albinism or pediatric disorders that they would have been caught well before they a person developed pulmonary fibrosis in their 60s. So we can kind of push those aside unless we really see something in the family history, but we could do panels and kind of blast and see if anything comes back. It's always better to test a patient who has the diagnosis rather than their unaffected relatives. In the cancer world, a lot of people are just trying to test everybody, whether they have cancer or not. But if you have a family history of a disease, it's better to test the person with the disease to see if any of these genes are even there, because you can have cancer or IPF for a different reason. So I always say if you're looking for a needle in a haystack, start in the right haystack. Then once we find that mutation, if we find one, then we can test other people, because then we know where that typo is. We know what book it's in, we know what page it's on, we know what word it's in, and then we can target that. The test results themselves can be quite complex. It's not a black or white answer. And that's why right now genetic testing isn't really routinely recommended. I think it's more patient-driven at this point. So this is the American College of Medical Genetics spectrum of classifying variants. Pretty cut and dry, right? Pretty simple. So If you don't have a type O at all, you're negative. You might have something that kind of looks like a type O, but they determine that it's nothing because a lot of people have it and they're fine. It's over here in the red where we start to treat it like a harmful gene variant, a harmful mutation. And mutation just means change in a gene. So a lot of people are going to variant. There's harmful variants, there's variants of uncertain significance, which is right here in the middle. And these are the most frustrating things across all genetic disciplines. So we see a lot of these. In the cancer world, up to 90% of them get reclassified to negative. In rare disease, sometimes they get pushed over, into the red, but they mainly stay in the blue and go down to negative. But in rare disease, it might go the other way towards the red more often. But it's hard to counsel on these because we don't know what it means for the patient, much less for their children. We know that this can be passed down to children or shared with siblings, but we don't know if it's really the culprit because we already have 8 to 10 genes we can test for. What if there's 5 more out there that you really have, and we just go with this and worry everybody? So we got to be careful with these results. And also, I just lost my train of thought. Well, I'll come back to it. So I know what I was going to say. At my conference I was at, they said, we just need to embrace uncertainty because it's just going to be a part of our genetic testing for a while until we understand this more. But what I want to drive home is a negative result in a gene associated with familial pulmonary fibrosis is really uninformative. All you've done is ruled out genes that we know about. It doesn't mean it's not inherited. It doesn't mean it is genetic, even though we think it probably is in a strong family history. But at least it's not those genes as far as what we can test for today. Our technology changes too over time. It's kind of like imaging. We had the X-ray, now we have CT and PET scans and imaging and ultrasound. Our genetic testing technology changes. Your DNA might not change, but our technology and our ability to look at it does. But what I want to bring up with this slide is that a negative result in a patient with pulmonary fibrosis just rules out those genes. This is why we don't want to start with an unaffected family member, because if they're negative, we don't know why they're negative. Is it because their family member even had a gene mutation in that gene and they just didn't get it, inherit it, or was it even there before? So it's really best to test somebody with the diagnosis in the family. Clinical management. This is the goal for every genetic test. How is it going to change my care? How is it going to change my outcome? And right now, it's questionable how we can use genetic information. We're still learning. We need to do more research. In the telomerase genes, we know they can affect the liver and the blood systems. But I'm pretty sure if you're seeing a doctor on a regular basis, especially if you're on drug, you're going to be having those kind of tests anyway. But these affect other body systems. Did they talk about that today in the liver and the okay. We know the telomerase genes can affect other body organs too, so they might want to watch that. And there might be some question if genetic testing would be helpful to know before a lung transplant as far as what regime to use afterwards. That's under study right now, so that might be helpful. In the surfactant genes, we know there's risk to both adults and children because it's mainly a pediatric presentation. And hopefully, especially those common variants, we might have therapies designed around. We heard about it this morning. And even with rare inherited disorders, we're seeing that in the ocular world. People have gotten their sight back with one gene through gene therapy. So it can happen, but again, it's probably going to be years before we can do that, but that's the hope. So, I always want to say, I don't have to tell most of you that, diagnosis of pulmonary fibrosis is pretty hard to take. as far as understanding what it is and the treatments. But when there's a family history, it seems, even more so for some patients. Most people have never heard of pulmonary fibrosis when they're diagnosed. But in families, they've had a long history with it, possibly. And so there's an awareness, a preconceived awareness already, and that might cause some depression or anxiety. Sometimes a patient could have cared for their mother or father who had it. And now, with the therapies and the drugs we have, hopefully that gives more people hope and some, especially more time. So, but I find across the board, most families, especially with the familial, they want that genetic information. They're really active in research and clinical trials, as well as those with no family history. And everyone's concerned about their relatives, of course. And really, the familial patients do have a stronger risk to their family members as opposed to the sporadic. But now we're learning about those common variants. We're learning about, like 1 to 5% of sporadic patients sometimes have a mutation in those rare genes. So it's a conversation, but I don't think every sporadic patient needs to have genetic counseling. But definitely when there's a family history and more evidence of these gene clinical spectrums, then that's definitely a conversation. So all in all, I think you started with this slide, but family history of any disease increases your risk for that disease. It does appear greater in the familial than in the sporadic forms. The common variants can even increase risk to relatives. They're still passed down too. But again, there's no way to really use that information right now as far as predicting diagnosis. And as far as screening for those at risk, Dr. Kropsky mentioned it, maybe, I've heard from, experts from my physicians that maybe do a baseline CT scan at 40 or 50, not CT scan, pulmonary function, or consider a CT scan. And I think I have a little bit different number than you had, or it's from the original paper. But in the early IPF study, I have 14% had early ILD on CT scan, and he had 23% today. So I think there is risk to unaffected family members, and it would be nice to have screening guidelines, because when we have guidelines, we have reasons to do genetic testing. Insurers are more likely to pay for it and the screening techniques. That's what's happening in cancer, and I think we can follow that model eventually, but we got to show how we're going to use genetic testing in order to help a patient. For risk and benefits of genetic testing, I always say learning genetic status is a risk and a benefit. Some people don't want to know. Some people do want to know. Some people feel empowered. Some people can plan their families around a gene mutation that's found in the family. Now you can actually prevent passing down a gene mutation in families. I'd just be careful. I wouldn't probably do it off a variant of uncertain significance, but definitely if it's a positive pathogenic mutation in the red area, that's something that can be considered for future generations. Monetary, sometimes it's expensive to get genetic testing done, but that cost is coming down, and a lot of labs offer testing for all the genes for $300. Found that out yesterday at my conference. A lot of people ask about genetic discrimination. And I know I've given this similar slides at other talks, but genetic discrimination, there was a law, federal law put into place in 2008. It's separate from the Affordable Care Act, and it relieved a lot of fears. It's called GINA. And basically what it does is it prevents health insurers and employers from using a positive genetic test result, or really any genetic test result, but come on, it's really positive that we're worried about. So it prevents them from using that against you to cut you off or make you pay higher prices, use it as a predisposition, not pre-existing, predisposition. Employers can't fire you or not promote you because you have a genetic mutation. But most people are worried about health insurance. But it doesn't do a few things too. Now, every state has its own form of GINA. This is the federal one that blankets it. I'm not a lawyer, I don't want to be, so I don't know every state law, but I'll tell you about the federal law. But it doesn't extend to elective insurances like life insurance or disability. So if you already have those in place, as long as they're not asking you to look in your record and you have a positive result in your record, there's no harm there. It's only when they're asking to look in your medical record, and it doesn't mean they will use it against you, it just means they can, unless your state has a certain law. So far, I don't know one state that has any law preventing life insurance from doing that. It doesn't mandate your insurance to pay for costs for tests or treatment either. Some insurers do, though, in other genetic conditions like breast cancer, colon cancer. It doesn't apply to these three, the military, federal employees, and the Indian Health Service, mainly because they have a similar law already in place before this one came along. But what I want everyone to take home is it doesn't protect the manifestation of disease. So that means, like, if you're diagnosed with, say, cystic fibrosis, you have cystic fibrosis. If you have a genetic test result in your medical record confirming that, this law only protects the test result, not the diagnosis. So really the biggest people who are at risk for discrimination from life insurance, disability, are unaffected family members, unaffected patients with a positive result in their record. If you already have the diagnosis, my bet is a life insurer is going to use that against you over a genetic test result. But again, it doesn't mean they will. It's just a possibility. So I always put up a resource slide. Of course, the Pulmonary Fibrosis Foundation is of course, on top. And a lot of people, if they don't want to do genetic testing, or maybe their genetic testing came up negative, they can bank their DNA. And I, just again, fresh off the conference, I asked Prevention Genetics, they bank it up for up to 50 years or more. For individuals who want to keep their DNA around. And of course the GINA information here. And then there's myself and Greg Cosgrove, Dr. Cosgrove, a couple years ago. Again, this is the genetic counseling service. It's better if you email me if you want to talk one-on-one. I can set up a time with you. But basically this is mainly just to have a conversation about family history, genetic questions, genetic risk. I can't order a test for you or help you get results done or things like that unless you come to National Jewish. But basically anybody can call me and we can have a conversation further. And then other ways, if you want genetic counseling and genetic testing, medical genetics clinics have genetic counselors, medical geneticists. You can go to National Society of Genetic Counselors website or the ABGC and do find a counselor. And there's also telehealth services like the Informed DNA that I work with or other genetic counseling services. A lot of times those will be listed in the National Society of Genetic Counselors as well. If you want to pursue genetic testing with your doctor. And then research. How are we going to find more genes if we don't do more research? So I always advocate go to clinicaltrials.gov, see if there's another biorepository for you to participate in or any clinical trials. And of course, what I oversaw at National Jewish and now the university, they're here. They have that familial study, but they're also enrolling sporadic patients that have sporadic disease, but they're siblings. So they've opened it up. So that's Julie Powers, and she's here with Rachel. I can't remember Rachel's last name right now. So in summary, everybody can wake up now. It's a complex disease with complex genetics. So there's no single gene that's going to tell us if we test you one way or the other. There might be in a rare amount of patients. And then genetic testing has limited utility and yield. We may not find anything, and what are we going to do with it when we do? But stay tuned. I think that's going to change. The tide's changing. And of course, anytime you're undergoing genetic testing, you should have someone like a genetic counselor or someone with genetics background kind of going over all those risks and benefits with you, because they do change over time. Because they're your advocate. They're not gatekeepers, they're your advocate. And of course, all of you need these resources and recognition and support. So thank you.